Thank you. So first, I would like to introduce myself. My name is Stéphanie Franchi, and I'm working in Bicêtre Hospital in Paris. And my department is particularly involved in pediatric liver disease. So at first, we wanted to work with supersonic imaging because of their UltraFast shear wave elastography. We considered the Explorer as an elastographometer that could provide also beamoid imaging and Doppler. But in fact, we realized with their increasing improvement that it is a complete ultrasound system that is good for all clinical practice and then can also provide advanced applications. So I will try to share with you this experience in the next slides. Ultrasonography is a great tool in children because they have a small size and the organs are quite superficial, so we can see them very nicely. But all is not so easy because they move, they cannot breath hold, sometimes, most of them, and the small size of the normal structure requires high spatial resolution. So we need high spatial resolution and high temporal resolution. So for the next slides, I will try to share with you our experience with UltraFast Ultrasound. We will begin with daily practice, then we will move on to our first result with shear wave imaging, elastography, and then we will finish with our first experiences with UltraFast Doppler. So let's begin with daily practice. First of all, and as said before with the previous speakers, it's very easy to work with the Explorer, and it's very functional. You will see the images provided in the next slides are done with the linear, microconvex, and curved probes. So let's begin with our youngest patient, premature babies. You can see the brain of a baby, and you can see that the quality of images are very good with the microconvex probe, as deep at 7 centimeters from the probe. Using the linear probe provides also very high-quality images of the middle line structure, and you can see that the vermis is very well seen, and the hippocampus is also very well defined. On this Doppler record, you can see if it works, the quality of the Doppler, and it's very, very good. Here for neonatal spine, there is a very high quality of analysis with the linear probe, and you can perfectly see with the microconvex probe the spinobulbar junction. No problem with neonatal hip, very high quality images. And here is a pathologic case with a 3-week-old baby vomiting, and you can perfectly see the thickening of the muscular layer of the pylorus that is related to hypertrophic pyloric stenosis. Here is the record performed with a microconvex probe on a 2-month-old baby, and you can see the very large field of view that permits to see the whole liver of this baby. Here is, let's move now to oldest patient. Here is a 2-year-old boy with abdominal pain and diarrhea, and the resident that began the examination with another ultrasound system had problems to say if he had or not appendicitis because the appendix was enlarged, but she couldn't go further in the analysis. I tried with the same system, and I couldn't ruled out with certainty the diagnosis of appendicitis. So I used the Explorer, and as you can see with the linear probe, we can perfectly see all the layers of the appendix and see that the enlargement is related to mucosa enlargement. So it was only lymphoid hyperplasia that did not require surgery. As I told you at the beginning of my talk, we are very involved in pediatric liver transplantation. And you can see here the quality of analysis of this liver graft on color Doppler. And even if the angle is not good for Doppler, you can see that we can perfectly define the bile duct that is dilated from the vessel behind that has the color. Here is another example of biliary complication on a liver graft, and you can see the quality of images provided by the microconvex probe and the linear probe showing the enlarged bile ducts with materials inside. So to conclude with this first part on daily practice, you can see that the Explorer provides high to very high quality of images, and this is adapted to all classical pediatric applications. I just can't wait to see what's going on the sides with a trapezoidal field of view with a linear probe. So we're going to move on now to advanced application. I will begin with shear wave elastography and show you our first results. So our first question it was, can we use shear wave elastography on children? Because the recommendations in adults is to perform the measurements in apnea and by intercostal way. And in patients, in pediatric patients, they frequently move, they can not breath hold, they have thin intercostal spaces, and for the specific case of pediatric liver graft, they usually have a left lobe that is located in the epigastric area, so we don't have always an intercostal way to perform the measurements. So we did a first feasibility study on healthy children to evaluate the feasibility of the measurements, and then we did an evaluation of shear wave elastography accuracy for the diagnosis of liver fibrosis in children. So I will show you briefly our results. So we performed the measurements in 51 healthy children in 5 groups of age. We compared the result provided by the linear and the curvilinear probe when possible. We did intercostal and epigastric measurement, free breathing versus apnea when possible. The results are that it was feasible in all cases. Then the mean stiffness value for normal pediatric liver was 6.5 kilopascal. The only significant difference we found was between the two probes, and there was no influence of sex, age, epigastric versus intercostal way, free breathing versus apnea. And the difference between the two probes was less than 1 kilopascal, so we have to go further to know if there is a real clinical impact of this difference. So to the question, we say, yes, we can use shear wave elastography on children with free breathing and intercostal or epigastric way. The second study concerned liver fibrosis in children. So we studied 55 children. Some of them had several liver biopsy. So we had 48 comparison between liver stiffness provided by shear wave elastography and fibrosis score scored by METAVIC score. The indication for liver biopsy was mainly liver transplantation and biliary atresia. As you can see on this slide, you have 5 examples of different level of fibrosis, from F0 no fibrosis to F4 cirrhosis. And you can see that on the color map, the color map becomes more heterogeneous as the fibrosis increases, and and the level of stiffness increases with the fibrosis. This result is in this table, where you can see that in function of the fibrosis score, you have an increasing value of liver stiffness. When we study the diagnostic accuracy of shear wave elastography, we use the area under the curve, and according to what is your question, and you can choose the threshold to have the better sensitivity specificity. So the first thing is that we have more than 90% of patients that are well classified, and when we want to make the difference between a normal liver, F0, and a liver with mild to moderate fibrosis, F1 and F2, with a threshold of 7.2 kilopascal, you have 90%, more than 90% of sensitivity and specificity. And this is very interesting, because it's very difficult for clinicians to detect very low grades or moderate grades of fibrosis. When there is cirrhosis, they can detect it easily with their hands. So is shear wave elastography a good test to evaluate liver fibrosis in children? The first results are very encouraging, and it could help for the early detection of liver disorders. It is certainly interesting to provide, to make longitudinal study to study the spontaneous evolution, the evolution of the disease under treatment or after treatment. And it could be a prognostic factor in certain disease. But work is in progress to perfectly define the field of application of shear-wave elastography. The main goal remains the optimization of liver biopsy in children. So for the last slides, I will share with you our first experiences with Doppler UltraFast. Here is the case of a 2-year-old baby who had a liver transplantation, and he was very enthusiastic about having his ultrasonography. So he was moving on the table, and using the UltraFast Doppler, it was very easy with a 3-second record to have the record on the artery and the 2 veins. So the main impact is time saving, because you don't have to try a long time to get the record of these 3 vessels. Here is an example on a 2-week-old baby with a renal pathology, and once again, with a 3-second record, you can perfectly study the artery and the vein. Here is a 1-month-old baby with a subcutaneous mass. You can see that there is a little mass on conventional Doppler with little vessels that are feeding the mass. When you use the UltraFast Doppler with the DCPI, you can see more clearly the feeding vessels, but you can also see that there are spots of colors within the mass. So are there artifacts or real vessels? When you put the spectrogram, you can perfectly see that this is an artery, and when you study the color spots within the mass, you can see that there are vessels, small arteries, and veins. So this is helpful for the characterization of the lesion. It was an hemangioma. So what application for UltraFast Doppler in children? The very fast acquisition is fine because it can provide less kinetic artifacts, and it is really a time-saving method. And the highest sensibility is very good to study small vessels, for example, in testes, and it is probably very good also to have a better vascular characterization of the tissues. So this is my last slide. So has UltraFast ultrasound advantages in children? Yes, it has. In BIMOD and conventional Doppler have a high quality for usual pediatric clinical applications. Shear-wave elastography is feasible in children, including neonates. The results are encouraging for the detection, evaluation, and follow-up of liver disorders, and it has to be evaluated in other organs. And UltraFast Doppler is a time-saving method. It can provide a better detection and characterization of small vessels, and it could help for tissue characterization. Thank you for your attention.